Oh, well, I'd rather be here than with Catherine.
We are going to reconvene the meeting again, everyone. Thank you so much, everyone. And with that, we will have our next person after reconvening our meeting. Sharon Hines, you're on.
Thank you. My name is Sharon Hines
Order,
and
order.
I live in Bradford. Thank you for the opportunity to testify.
Sharon, can you start again and turn your camera on if you are up to it?
I actually am flat on my back with an
No
acute
worries.
back episode, so I prefer not to turn the camera on.
No worries. Please go ahead.
Okay. Can you hear me okay?
Very well now that everybody is quieting down.
As you know, my name is Sharon Hines and I live in Bradford. I thank you for the opportunity to testify in support of SB 1076, an act concerning aid and dying for terminally ill patients. I have stage 4 lung cancer and have shared my personal story with this committee several times in recent years. Honestly, it's exhausting to do so. As a former hospice nurse, an oncology nurse practitioner with more than 30 years of experience, I know the pain and suffering that often accompanies an advanced cancer diagnosis is frequently unavoidable. Despite the best hospice care, not all pain can be controlled, nor will every patient have a peaceful end to their life. The fear and worry about how will I die, when will I die, and how much suffering will I have to endure has been haunting. 2 years ago, after another unsuccessful attempt to pass aid in dying here in Connecticut, I established residency in a state that does include it as part of their end-of-life care options. I am by nature positive and hopeful. I am not depressed. I am hopeful for a continued response to treatment, hopeful for a good quality of life, and hopeful for a peaceful death. What gives me hope for a peaceful death is knowing that if needed, I will have access to aid in dying. I am no longer preoccupied with dying from lung cancer that not only takes your breath away, but in the case of cancer that is spread to your brain, your mind too. In fact, I really think about it now. There is no amount of therapy or medication that provides the peace of mind that I now have in knowing I will have access to aid in dying if needed. It offers a more humane, gentle, and peaceful ending to the one I face without it. What would make it even better is not having to take on a disruptive and burdensome move out of state and leave my family and friends behind when they are needed the most. Connecticut has been my home for my entire life. I did all my schooling here, including nursing school, undergraduate, graduate, and graduate school. I was married here to a lifelong Connecticut resident, and he and I raised our son here. My son and his wife and their 15-month-old daughter, Lilia, my one and only grandchild, who fills my heart with such joy, moved back to Connecticut last year to be closer to family. Having them close by has been some of the best medicine ever. In closing, with the additional safeguards that everyone has worked so hard to put in place in this bill, it's time to pass this legislation. How many more people have to die waiting, or if able, move to another state to have access to aid in dying? Thank you.
Thank you so much. Thank you for your courage and the battle that you're fighting. We are rooting for you. We have all our prayers and love for you. Thank you.
Thank
Seeing no
you.
questions or comments, we will move on to the next person on our list, which is Mr. Luther Weeks. Welcome.
Welcome. Yes. Chairs and members of the committee, my name is Luther Weeks, testifying for myself and Secular Connecticut, and for the first time as a patient, like our last speaker. I especially urge those members of the committee, General Assembly, and public that are undecided or currently against medical aid in dying to be open to my remarks. It's been said that people who are initially against aid in dying change their mind once they go through an agonizing death with a family member, a friend, or confront their own death. I was never against aid in dying, and since 2012, I have come in closer contact with death while becoming increasingly involved in working to provide this choice to all. This is a choice much like abortion, a choice which each of us should have available to make for ourselves, even if we believe we would never make that choice. Making that choice available to me and others can provide peace of mind right now, long before we might choose to avail of ourselves of that prescription. My journey and testimony started in late 2012 when I, as executor for the estate of my cousin who died of brain cancer. I sat with him on his last agonizing, non-communicative day of struggle. I do not know what his choice would have been, yet I wish that he had that choice available. Even after due consideration, he chose not to exercise it. In 2020, I became friends with Herb Hoffman, father of Kim Hoffman, both of whom testified here last year. Kim posthumously and Herb from his deathbed in California, where he moved shortly after Kim's death. Days after that testimony, Herb ended his life in dignity at the time of his choosing, surrounded by family. Ironically, last year, the day after I testified, I was diagnosed with rapidly advancing metastasized prostate cancer. I contemplated what would happen if I died in a few weeks. That was actually freeing to face death and contemplate how it might be with dignity. Relief for me was to learn a few months later that through chemo, I will likely be around another 10 to 15 years unless something else gets me first. Like Herb, I will likely reach a point where further chemo will kill me as surely as cancer. Members of the General Assembly, I ask you that you give me and all of your constituents that choice. 75% of us want that choice. Who knows when and if you'll learn that you will want it too. Thank you.
Thank you so much, Luther. I did not realize about this. I had a predicted testimony in my mind about you, but it wasn't this.
Okay.
I'm so sorry about the diagnosis, and I know you've been speaking to us in the last few years, and I hope you heal and get better. And the good news is the treatments are there. We're going to be rooting for you for your success.
Yeah, and the good news is that actually it's a transformative experience. I feel much more comfortable with death than I did before.
Thank you. Seeing no question, Representative McCarthy. Wait.
Thank you, Mr. Chair. Thank you, Mr. Weeks, and I share the sentiments of my good co-chair. And I'm sorry to hear the news, but I'm also glad to hear the news of the
Okay.
treatment. And kind of along the lines of my conversation with the last, the Father Sullivan who testified. One of the things that we've heard today from folks is that once you've experienced a bad death, you would then be a proponent of this choice. And do you think it would be fair to say that that's not true for everyone? That in fact, for some people, that certainly is the thing that changes their perspective and opinion, but for others, it wouldn't, just as I asked Father Sullivan, you know, on the opposite side.
Yeah, people experience everything differently. But then again, we all might change our mind from time to time. If I was diagnosed with 6 months left to live, I would get that prescription as soon as possible. But that doesn't mean I'm going to use it and use it right away. If I were to live for 2 more years, great. It's only when, life is not really worth living and it's, much worse that I would ever choose to actually take that.
Thank you for your answer. And I hear you saying we all experience life and death differently. Thank you, Mr. Weeks. Thank you, Mr. Chair.
Thank you. Seeing no other questions or comments, we thank you for being here and your patience with us today.
You're
For the people who are physically over here, would you be able to raise your hands if you're waiting to testify? 1, 2, 3, 4 individuals. I'm going to as 5. Oh, sorry, you're in my blind spot. So if the people and as the chair and if my co-chair would allow as well, with the anticipated changes in the weather, a lot of the people who are on the Zoom, I presume you're in a safe environment. If you would allow me, there are 5 people who are physically here. I would rather have them speak. I'm breaking the rule because I want them to go home safely. Some of them may have to drive a long distance. If you are okay, we'll go ahead. And I see a lot of people nodding their heads, and I think we should be able to do this just out of respect for everybody's safety. Okay, with that, I'm going to start with maybe the one of you guys up there. Yes, go ahead. And please state your name as well so we can, thank you so much. And I apologize to the people who are online right now. We'll make up for it. Yes, the button right there. Perfect.
Yeah. I can say good evening now.
Yes. What is your name?
I'm Reverend Dr. Jan Carlson Bull, and I reside in Middletown, Connecticut. I speak on behalf of SB 1076, Medical Aid in Dying, more accurately called Compassion in Dying or Death with Dignity. I come before you as a close friend of Linda Bluestein, for whom this bill is intensely personal. You heard earlier Linda's testimony, and you will hear later from her husband, Dr. Paul Bluestein. You know that Linda, my dear friend, is amid end-stage fallopian tube cancer. And she and her husband, Dr. Paul Bluestein, are passionate advocates for this legislation and have been for many years. My ministry as a Unitarian Universalist minister has been grounded in the belief that God is love. Much as it is impossible for any of us to get into the mind of God and to say God is this, God is that, the God that I believe in is a God of love. And needless suffering is antithetical to my understanding of a loving God. I do not believe that God is sadistic. For those who argue that suicide is against the will of God, medical aid in dying is not suicide. A very dear friend lost his sister to suicide. Brutal. I have also presided at the memorial services of at least 2 or 3 people who committed suicide. Medical aid in dying is not suicide. I have seen and known suicide. Linda does not want to die. She is one of the most vital people I know. She loves her life. But without the option of this legislation, she faces a death that is extremely painful and laden with anxiety, even with palliative care now and hospice at the end, which, is not necessarily divorced from medical aid in dying by any means. But even then, she would face an extremely painful and anxiety-ridden death. Linda and her husband, Paul, are joined in their support by the majority, 75% of Connecticut residents. I know some have argued with the numbers, but these are the numbers that keep coming back. They're also joined by the majority of Roman Catholics and liberal Protestants and disabled individuals. As a minister, how can I possibly forget the congregant who spoke again and again of his late wife and how she died after a harrowing struggle with cancer? She only wanted to pass peacefully, surrounded by her family. And it's ironic that Reverend Sullivan, who testified with such pastoral presence, and he definitely did, talked about how that end stage of life can be redemptive because you can be surrounded by family and talk with people you haven't talked with in years. Precisely. That is part of what Death with Dignity and Medical Aid in Dying is about. So that if you have a very limited time in which to live, you can plan. You may not use that medication, but you can plan to have your family and your loved ones near you as you pass on. And it can be a time of peace rather than a time of trauma for you. And certainly we heard from the gentleman who is an attorney in New York who witnessed the horrible, agonizing death of his father.
Ms. Carlson Bull, your time is up.
I'll be finished shortly. So Connecticut has not yet legislated this option, but I am so hopeful and beseech you to pass this legislation at long last. Life is a gift, so is a peaceful death. When any of us receives a terminal diagnosis that promises only a death of pain and suffering, where is compassion? Where is mercy when we breathe our last? Compassion and mercy are up to you. Our Public Health Committee, our Connecticut legislators. Thank you, and I welcome your questions.
Thank you so much for your testimony. Thank you. I just want to thank you for being here all day and also your beautiful words. From what I gather, your perspective is clear that this is not suicide, and that does not mean that the person is not going to be loved and be in a higher presence, if from your understanding, right?
And most definitely. And I thank you for being here all day. I thank you. I mean, it's been a marathon.
Keep us in your prayers. Thank you so much. Seeing
Thank
no
you.
other questions or comments, we will ask, I don't know your name, but you can come too. Thank you. And thank you for everybody on Zoom for your patience with us. We want to just get everybody home safely. Thank you.
Thank you, co-chairs Anwar and McCarthy Vahey and members of the committee. My name is Nicole Pascarell. Currently, I'm a master's student at the University of Connecticut, right across the street almost. I'm also a social worker in a skilled nursing facility in Middletown. I am here today to deeply urge you all to support the bill aiding in dying for terminally ill patients. In my 2 very short years in the medical field, I have already seen the immense amount of pain and suffering that many people go through during the last few months of their lives. Many times I've entered a new patient's room who has come to us for end-of-life care, and before I even can tell them my name, they look me in the eyes and beg me to let them go. They don't know that I'm not technically a medical professional, I'm a social worker, and they think that I have the option to withhold their medication from them. I want to be clear that this issue is not a mental health issue. With every patient that enters my facility, I do an assessment with them commonly known as the PHQ-9. This is an assessment that evaluates symptoms of depression or anxiety in somebody and how often they are feeling those symptoms. With many of my patients who have no history of mental illness, they report symptoms that are mainly coming from their illness. These include things like lack of sleep, appetite, and restlessness due to the amount of pain that they are in, not underlying mental illness. The parameters of this bill make it so that a person must undergo a mental health evaluation to ensure they are not making this decision based on a mental illness, as many people in opposition have said today. No one is ever forced to utilize this option. This simply gives people a choice to have autonomy and dignity and to die peacefully with much less pain and suffering rather than being forced to live in pain in their final days. I thank you for your time today and finally ask one more time for your support on this issue.
Thank you so much, Ms. Pascarell. Anyone has any questions or comments? Seeing none, we want to thank you for being here today.
Thank you so much.
Thank you. Next person on our list is Kristen Keska, if you can join us.
I would like all that's listening to my testimony today to open up my submitted written testimony. If you are new to this committee, you can read more details about my mother's life and death at the bottom. There you can see pictures of my mama, including a photo of her the night before her death. Even if you're struggling to accept this bill, you can honor her and her memory of all mothers lost to ovarian cancer. Yet please allow me to be her voice today in support of SB 1076. I fully support medical aid in dying. I've always supported it, but I was a quiet supporter. My mother's death helped me find my voice since hers is denied. Her sickness allowed me to see death, the hospice system, which I fully respect. And because of my activism, the Connecticut political system up close. Members of the Public Health Committee and testifier, Mr. Wolfgang, I am one of the people who had a poster on the wall outside. My mom and I are not props. I'm just an average Connecticut resident. I'm a simple high school US history teacher and government teacher. Matter of fact, Rep. Jenga intern, which I ran into today, was one of my former AP government students. I'm a mom of 2 adorable yet sassy young girls, a softball coach, and advisor of a very active community service club. At the same time, I can promise that I am not a heathen. To suggest that or that any of my advocate friends are props because of our circumstance and advocacy hurts. Testifying yearly leads to hours of extra tears and trauma. I relive the 8 weeks of my mom's terminal illness every time. None of the opposition here has a personal story of misuse, nor could they, because the medicine is self-ingested for the 6,000 people in 20 years who have used it. But many of those here testifying today have been directly impacted by the lack of this bill in Connecticut. I respect the opposition and when they testify in support of natural passing of their loved one and their spiritual connection to God. I respect those testimonies and they make me tear up too. Death in any form is emotional. I want to spend my time addressing questions of legislators directly on dignity, medicine disposal, my failure as her de facto doctor, my thoughts on slippery slope argument when compared to other nations and off-market drugs. Representative Foster, you had asked if Tyrone Bellars believed if his family member had adequate management at the end of their life, that it would change and the system change would have changed their dignity with death. My mom chose to have a DNR in her will for decades, knowing what that would mean. My mom planned her own funeral a few weeks before her death, before she started chemotherapy. She chose palliative care with chemotherapy. Then my mom chose to stop palliative care. She chose hospice at home. We did not know at the time what that meant, but we rocked it. She had the most important people, a teacher, a medical marketer, a medical tech supporter, and a truck driver as her de facto medical care. And we could call a 24/7 hospice nurse questions. If they deemed the situation was beyond usual, they would come quickly and visit. I don't fault the system. At the moment, I may have been angry, but that was because my mom was dying. She was suffering through the physical pains of death and mental pains of repeating what she saw her father go through. She wanted medical aid in dying, but I could not grant it to her. If I gave her the morphine that I had in my possession, I would be her murderer per Connecticut law. Senator Arwar and Representative Carpino, you asked about the disposal of the medicine. I don't recall having a choice from the hospice nurse, nor would I have opposed her method of disposal. When my mom finally passed, we cried, we called her brothers, then we called hospice. The caring nurse came 15 minutes later. She pronounced her dead, completed the legal forms, and then immediately brought the plastic trash bag of kitty litter to the kitchen table. She took notes of all the medicines that we were told to open and dump into the bag. Then we threw the bag of destroyed medicines in the trash. Just so you know, I think that dumping the medicine was my outlet after watching my mother drown to death because of her cancer. I threw out
Excuse me,
everything.
Miss Kreska, your time is up. Thank you.
Morphine, anxiety medicine, all her medicines from before her cancer, even the expired vitamins, some of them 5 years old. And I'd also like to note that the cause of her death listed was ovarian cancer, not drowning on her own fluids. I could talk about again the type of medicine. I could talk about again why we are not Canada or Netherlands. And I could talk about why this bill is not a slippery slope or why I believe in off medicine if you ask me those questions, because I have small paragraphs. I promise they're small on those.
And if they are going to be within 30 to 50 seconds, please go ahead and answer those questions.
Well, which one would you like first? Like, which one would
Why
you
are we
prefer the
not
most?
Netherlands?
The Netherlands, okay. So being the government teacher that I am, Senator Anwar, I'd like to address your question to both Tim and others about the slippery slope. I've heard the opposition discuss Netherlands and Canada and broadly Europe. I teach American history and government, and we are not these nations. For those who have socialized medical care for all, America does not. Those nations have central forms of government. They do not have federalism. The idea that we share an individualized power of both the national government and the state government. Our nation, the state government laws matter and the decisions are protected by the 10th Amendment. That is why this is not a national policy. We cannot as a nation agree upon women's rights, the death penalty, voting rights, gun rights, or marijuana policies. States do what is best for their citizens. You as the legislative branch are the protectors of the citizens and the creators of the law and have a more day-to-day impact on the residents of Connecticut than the federal government does. And I don't believe that any national politician of these countries have contacted you directly when you're trying to make this law. Is there any other questions I can answer? for you?
Representative Parker has a question.
Not a question. I just wanted to thank you for being here. I'm sorry for your loss. I appreciate you pointing us to your testimony. It was a real treat to get to see photos of your mom and your family.
It's very nice to see her healthy, and
Yeah.
then it's a harsh reminder on that last photo. You can even see that tumor, how big that tumor was. That was 8 weeks.
Thank you.
Thank
Mr. Chair.
you. Thank you so much. Seeing no questions or comments, we will move to the next person on our.
Thank you very much.
Oh, who's over here, Mr. John Warburg. Thank you, Mr. Warburg, for being here.
I can't imagine what I can say that hasn't already been said, but thank you to the committee for hearing this bill. I strongly support enacting medical aid in dying in Connecticut. I think it's important to keep in mind that in states where aid in dying is available. It is simply an option. It is not a requirement. It is not a directive. It is not a call to action. It is simply an option for which only a tiny percentage of people will ever qualify. And of that tiny percentage, an even smaller percentage will ever use it. In 25 years across 11 jurisdictions covering 70 million people, 6,000 people, or I think Tim said 6,300 people have ever used MAID. It's a tiny, tiny number. In other words, its use is extremely rare, but its impact on reducing suffering and bringing peace of mind to thousands of others who at least know that the option is available is huge. By denying me this option at the end of my life, the state of Connecticut is essentially telling me that if I am terminally ill and palliative care and medical treatment can no longer relieve my suffering, I have no choice but to continue to suffer, unless I'm willing to violently take my own life, which ironically is perfectly legal. I totally understand why people's religious values might cause them to reject aid in dying. And I respect their right to say no. And I respect their right to urge others to say no. But I don't see why their choice and right to say no should in any way impinge on my choice and right to say yes. The two can live peaceably side by side. So even if you are a legislator who is personally against aid in dying, I hope you will respect my right to decide for myself. A yes vote for this legislation is not an abandonment of your own personal values or an abandonment of vulnerable populations for whom there are multiple safeguards. It is simply a confirmation of one of our democracy's most precious values, the right to self-determination. If we use the potential for abuse as the reason not to pass this law, then we might as well reverse all laws that give people a right to make any kind of self-determination, because there will always be the possibility, no matter how remote in the case of aid in dying, that people will be manipulated by others. In fact, we might as well just take away everyone's free will altogether. But of course, that is nonsense. Our government needs to have more faith in people's ability to decide what's best for themselves and put more trust in the medical and legal system's ability to prevent abuse of those freedoms. Thank you for listening to my testimony. I'd welcome any questions.
Thank you, Mr. Warburg, for your very powerful testimony. So I think would you be able to expand a little bit about how somebody else's right, because it's something that resonates with me as a physician who is hardwired to protect people. I do not have the right to put my views onto other patients. If you can expand onto that.
Yeah, I think about the Hippocratic Oath, which says do no harm. I think we have to ask ourselves, who gets to define harm? Who gets to define suffering? And it should be the patient, not the doctor. And I actually think that our medical system in many cases does more harm by artificially extending life at any cost, even when the patient is suffering terribly and has no more meaningful life to live. In situations like that, denying aid in dying rather than allowing it ultimately causes more harm. And I think it is absolutely the individual's choice based on their own personal values. And in my making that choice, I am in no way trying to exhort others to follow my example. It is purely a personal choice.
Thank you so much. Representative McCarthy, he has a question.
Thank you very much, Mr. Chair. And Mr. Warburg, I just wanted to say thank you. I said to you in the brief recess, you are going in the opposite direction. You came up here midday so that you could be here in person.
Yeah.
And I appreciate you being here and the way you've articulated the position that you have in favor of this and saying, why should others' rights to say no be any stronger than my right to say yes? I appreciate your clarity and
Thank you.
even brevity with that. So
Thank you.
Thank you, Mr. Chair.
Thank you. Seeing no other questions or comments, we appreciate you being here and your patience with us today. Next is Tessa Markey. Welcome. Thank you for your patience.
I talk pretty fast too. I am here in support of SB 1076, aid concerning, act concerning aid in dying for terminally ill patients. I want to thank everybody. I'm not going to do it by name because we're rushing. I think this is the 8th time in the past 9 years that I've testified on bills similar to this one. And my experiences over these years have put me in close contact with many people who beg for an end of life as they experience the pain and fear they must suffer through. Whenever possible, I've submitted testimony. It's all in the record and you can certainly read it. Testimony was submitted in writing this week, but when I was listening to some of the earlier testimony, I want to go in that direction at this time. So there was testimony from someone about another supporter of this bill about her journey with pancreatic cancer. And I've spoken previously about friends who had a choice and friends who did not have a choice and friends who did not want to hasten their death in any way. And I have, in fact, known people who committed suicide. These are all very different circumstances. And I've never spoken about my father. So sorry. He was diagnosed at 67. He had only 3 months to live after that diagnosis. He died in a hospital corridor in the basement. They were going to do a test on him. He was bleeding internally from the experimental surgery that he had suffered through 2 weeks before. An hour prior to his death, I was holding his hand and he kept pressing on my thumb, very vigorously pressing on my thumb because he thought it was the button to get more morphine into his system. That's the kind of pain that he was in. And he had told me all his life that what was important was not the length of your life, but the quality of life that you had. And he said to me that if any doctor ever said that his recovery would result in a quality of life less than 70%, we were to let him go. When his doctor came out of intensive care, at a certain point, he had said, I said, what is his quality of life recovery percentage? And he said 30 to 40%. And I said, that's not enough. My sister, who was a physician, looked at me absolutely in shock because she had never thought about that. And when she died of cancer, she died in the hospital as well.
Excuse me, Ms. Markey, but your time is up. Thank you.
Okay. So I ask you to vote in favor of the bill, and I hope we all die in a dignified, pain-free manner. And I'm not going to say anymore. Thank you.
Thank you so much for your testimony and your question. Oh. Yeah, Representative Kennedy has a comment or question.
Just a comment. I just want to thank you, Tessa, for being here. I know you've been through a lot. I didn't realize how much you'd been through with your father, but I know you'd been back and forth with your mom. It's a lot of times coming up here to testify. So I hope for your sake, we get the resolve that you want this time. So thank you so much for your very emotional testimony. I really appreciate it. Thank you, Mr. Chairman.
I wish you all good health. Good health.
Thank you. Thank you. With that, we'll move back on number 93, Joy Cipolo, who is on Zoom. Welcome. And for all the people who are here who have testified, if you want to join and listen in online, you can listen to us on YouTube. Be safe as you drive back. Thank you. Go ahead, Joy. Thank you so much. Sorry we had you wait.
That's okay. Thank you for still hanging in there and hearing all of our testimonies. So I appreciate that. As you know, my name is Joy Sapolo. Kim Hoffman was my wife. Some of you here today may be familiar with Kim's testimony and passionate advocacy work in favor of the medical aid in dying bill. Kim passed away on January 18th, 2022. And I continue her relentless efforts to pass this legislation in Connecticut. Kim was an impressive, energetic, talented woman. Her humor, her sensitivity, vulnerability, and caring for others did not go unnoticed. She made long-lasting impressions on almost everyone who knew her, even some of you here in the room. When she was focused on something, she gave it her all. She had 3 master's degrees, was a very talented musician, a highly regarded high school social worker, and tennis coach. Kim had ovarian cancer. Even while battling ovarian cancer, she lived life to the fullest. She would never, ever consider taking her own life. She was not suicidal. That word keeps coming up today, and it's very painful to hear that word. She met with some of the legislators a couple of years before she died, some of them face to face, sharing her story, because there's no cure for ovarian cancer. She knew that the day would come that she would be facing end of life. So she met with some of you pleading to have an option, an end of life option. She impacted many of you that are here today. However, despite of the best doctors, the care team, palliative care, she suffered greatly and died waiting for that option. Imagine being unable to live your final days as you did your entire life. This year, I would ask you to imagine what it would be like if you or your loved one heard the news from 2 different doctors that you have less than 6 months to live. This was brought up a little bit throughout the day, but really think about what that would feel like. For Kim, she wanted to know, is she going to die comfortably or will it be painful? Her doctors told us, be prepared. It's not going to be easy. Imagine what that feels like, especially after watching your own mother die a terribly painful death, pleading and crying out that she wanted to die. Imagine being someone like Kim, who had just been given less than 6 months to live. Even with all of the assistance hospice was able to provide, Kim, who was barely able to communicate due to being in a semi-conscious state due to the cancer and high doses of medication, she whispered to me, I wish we moved to Maine.
Excuse
As
me,
you know-
Mr. Paula, your time is up. Thank you.
I just want to end with imagine helping residents of Connecticut having the freedom of choosing a peaceful death. Please make Bill SB 1076 a reality so we no longer must imagine it. Thank you for your time.
Thank you, Joy, for your testimony, and thank you for sharing about Kim again with us. Her advocacy, her passion, her commitment to making sure that she was helping others even when she was in great pain is something that has impacted all individuals who have interacted with her. So we truly appreciate you here, and thank you for spending essentially the entire day here. And I'm glad you are safe right now where you are at, rather than with the weather changes. Seeing no comments or questions, we will move to the next person on our list, which is Robert Hale. Mr. Hale, you're on. Thank you so much for your patience with us, and sorry we delayed you a little bit because of the people who were in the room who wanted to testify first.
Thank you, Senator Anwar. I had intended to testify in person, but I guess things worked out. I appreciate the hearing. Your conduct of the hearing has been very fair and unbiased, and I've been listening throughout the day to the testimony of many others. First, I wanted to make a few remarks, and I hope I don't go over my time. There were a couple of other individuals who wanted to testify, or at least one that wanted to testify. Rabbi Noson Leiter of Torah Jews for Decency. He was number 69 on the list, and unfortunately, he was passed over. I think he had attempted to register by telephone. I recently got a phone call from him. He said he may be available to testify if you could take him out of order. Also, Bill O'Brien did not testify. I don't really know the reason. Bill O'Brien of Connecticut Right to Life. I know Mr. O'Brien submitted written testimony. I've read it. He was number 15 on the list. For those who are interested in reading Mr. O'Brien's testimony, I found it very persuasive and enlightening. He is, his name is not alphabetized correctly on the regular list, the alphabetical list of people who were preparing to testify. His name got put in under Brian, B-R-I-E-N. His actual name is O'Brien. So if anyone would like to read his testimony, I would encourage them to do so, but look under B. So I had originally planned to testify against this bill. I'm still testifying against it. I must admit that I've listened to many, many emotional stories, many stories of pain. It's not so much about the emotion, it's about the pain. It's about the suffering. And I found myself almost persuaded by the emotion. And yet being an attorney, being schooled in logic and reason, I had to restrain myself and remember it's not necessarily about emotion. It's about logic and reason. It's about the consequences of this sorts of legislation, and it's about the protections for individuals. I must digress. As an attorney, I had also planned to testify in opposition to the written testimony of Attorney James L. Young.
Excuse me, Mr. Hale, but your time is up. Thank you.
I'd like to just finish the sentence or two, if I may. I have prepared written testimony, which I have submitted. My written testimony is very extensive. I would ask you to read it. I have tried to respond to Mr. Young's written testimony point by point. I do not agree. I do not believe the protections of the bill are adequate, and I think that's all detailed in my written testimony. Above all, I believe this bill is about changing my opposition to this bill is about changing the role of a physician in our society. I think it is very dangerous to change the role of a physician. And the Hippocratic Oath is not just about doing no harm. It specifically states, I will give no poison, for lack of a better word, to someone to end their life, if requested. Specifically says that. And there are good reasons for that historically. I thank you for your time.
Thank you, Attorney Hale. Thank you for your patience and your testimony, and thank you for suggesting to us specific testimonies to read twice. Seeing no questions or comments, we will move to another person who is on the list over here is Jessica Power. Jessica Power, you're on. Thank you. And welcome, and thank you for your patience and for being here. Turn the light on, the mic on. There you go. Not now it is. Yes.
Thank you. Good evening. Thank you, co-chairs and esteemed colleagues. Thank you for the opportunity to testify against SB 1076 an act concerning aid in dying for terminally ill patients. My name is Jessica Power. I am a resident of Coventry, Connecticut, and I am currently a senior at UConn studying human development and family sciences. During my freshman year at UConn, my uncle Hugh passed away from melanoma. Prior to passing, he had been informed to the fact that he only had a few months to live. Throughout the hardest days of his life, my uncle grew closer to all of his children, and his ex-wife allowed him to pass away in a bed in her home so that his children could be by his side. My uncle Hugh was not only a beloved uncle, but also a beloved teacher, son, brother, and friend. With SB 1076, my uncle could have missed out on spending the last days of his life with the people he loved most, his children. SB 1076 would have also made it possible for my uncle to have taken his own life without anyone in his family knowing. All of us can agree that the end of life for someone who is terminally ill is very difficult. However, instead of providing a means for suicide, we should be providing compassion. The American Medical Association once stated that physician-assisted suicide is fundamentally incompatible with the physician's role as healer, would be difficult or impossible to control, and would pose serious societal risks. They also stated that patients should not be abandoned while they are dying, and instead should be provided hospice, pastoral support, family counseling, emotional support, and pain control. While it can be argued that not everyone has a support system to stand by them at the end of their life, why are we fighting for legislation that would kill these individuals when instead we could develop public policy that makes sure that these individuals have networks of support at the end of their lives? SB 1076 should be opposed as it limits the possibility for someone who is at the end of their life to be shown real love and compassion. And something else I wanted to mention that wasn't in my written testimony is this morning, the representative from Compassionate Choices mentioned a study that a poll that was done, I think in 2021, that said that 75% of Connecticut residents supported aid in dying legislation. I'm also an accelerated master's student in the School of Public Policy at UConn, and currently I'm taking a class in public opinion. And one of the big things we've been talking about is that word choice matters. I would be interested in seeing if the average Connecticut resident knew what aid in dying meant. Do they think this means palliative care? Do they think this means hospice? I'd be interested in seeing a study if they would oppose it if it was worded as assisted suicide instead of aid in
Ms. Power,
dying.
your 3 minutes is expired.
Okay, thank you.
Thank you so much for your testimony. Thank you for being here. Seeing no questions or comments, we want to thank you for your time with us today.
Thank you.
Next is Gregory Scheimer. Thank you. Welcome.
Good evening. What a
Good
lovely
evening.
day, right? Thank you for having me. I have been testifying in front of this committee for the last 3-4 years, give or take. And I am in support of this particular bill. The reasons why, more or less, is because of the passing of my late wife, Tracy Gamer Fanning, who died of a brain tumor, who has saved and helped thousands, hundreds of families in the state. She made the most of the 12 years that she was here. My mother died in 2015 from lung cancer. And they both died in ways that were less than dignified. Nobody, no one should die this way. No one. My dog, I was allowed to put down because they had a tumor in her chest. My late wife had to sit there while she was emaciated, dealing with drugs and hallucination. There is no dignity in this, no caring. There is nothing about this. And for the record, for whoever said this earlier on in this testimony, I am no prop. I am a late wife's husband. I'm a widower. And the people who have also dialed into this are the same way. Do not belittle their pain. Do not belittle who they are. This is all about choice. not numbers. This is all about statistics? No. This is about individual choice. I implore the committee to move forward. I implore the committee to empower the people who should have this choice to continue. Because this is not about slippery slopes. This is not about anything other than the freedom to be able to do what people should do at the end of their lives. When I saw my late wife dying on her bed, incapable of taking a shower, my mother incapable of walking to the car after her third chemo treatment, forget this. And there's not a single person in this room given this choice, not a single one would take that choice given to them. Thank you, everyone. I appreciate your time.
Thank you so much for your testimony. Seeing Representative Calvers DeGraw has a question or comment.
Of course.
Just a quick comment. Greg, I just want to thank you for being here today. I want to thank you for being here for all the years that you testified. Tracy was a huge advocate for so many wonderful issues in front of the legislature. And, we all share in the pain of her loss and feel it every day in the building. So thank you so much for sticking with us and being here tonight to testify really on her behalf. Thank you.
Thank
you, Mr. Chair.
Thank you. Thank you for your testimony. I'm so sorry for your loss.
Thank you.
We hear you. Next is Joshua Seba. I hope I didn't pronounce your name inaccurately. Good. Welcome.
Good evening, esteemed chairman and colleagues. My name is Joshua Seba. I am an engineering student at the University of Connecticut. I'm a resident of Wilmington, Connecticut, and I've lived there my entire life. And I thank you for the opportunity to testify against Senate Bill 1076. I know you've all heard from a lot of concerned citizens today with many different backgrounds and personal stories that make them invested in the legislative future of this bill. And I'm aware that I am either the last in person or last in person speaker. So I'd like to leave you with 2 points, and so I'll be one of probably the final speakers here in person today. The first is about my societal concerns about this bill. I have seen how much of a slippery slope this issue can instigate by looking to other places that have started down a similar path as this bill would take Connecticut. In 2021, just 5 years after legalizing aid and dying for terminally ill patients in Canada, euthanasia was legalized for patients whose life was not affected by a terminal illness. And there are now discussions among legislators there to expand assisted suicide to include not just terminally ill patients, but also mentally ill patients. These are the exact same scenarios that result in suicides, except in this case, doctors would help facilitate that person killing themselves. How can a mentally ill person be diagnosed to be of sound mind to make a decision about ending their own life? Also in 2021, New Mexico passed an expanded form of assisted suicide that allowed the waiting period for aid and dying to be reduced down to just 48 hours or even waived entirely so that the person requesting a terminal dose of medication could be administered that dosage the day they requested it. A bad day could result in the petition putting into motion a process that would result in taking their own life. There's no difference between this and suicide. So even though we will not see national passage of assisted suicide in the US like was done in Canada, we can still see it done at the state level, which is just as dangerous for the citizens living in those states. This is a Pandora's box that cannot be undone once it is opened, and it can only get worse. The second and final point I have is regarding the dignity of human life. All life has value, and I have seen that firsthand. When I was in middle school, my uncle was diagnosed with pancreatic cancer, and a year later from that time, he had already passed away. His tragic and sudden terminal illness hit myself and my entire family very hard, but we are all thankful for getting one final year with him, and I cherish the final memories that I had with him. Aid and dying could have taken my uncle away from us sooner, whereas he got another year to spend surrounded by his family. I hold that it is more dignifying to be treated with compassion and loving care than to administer a lethal drug to oneself hours before dying a self-inflicted death. I say we should concentrate resources to uplift a person with hope through a support system that will care for them and their needs as they go through difficult and potentially painful days ahead, instead of encouraging medically assisted suicide. I sincerely hope you'll take into consideration my perspective and the concerns I have raised about this bill. I thank you for your time.
Thank you so much for your testimony. We appreciate you being here, seeing no comments or questions. Thank you.
Thank you.
Safe travel back to Yukon.
Thank you.
Next person on the list is Laura Copland. Ms. Copland, you're on. Thank you so much for your patience with us today.
Of
Welcome.
course, thank you. My name is Laura Copeland, and I live in Ivoryton, and I thank you for the opportunity to testify in support of SB 1076. Today, you've heard similar stories to what you'll hear from me, but I hope the familiarity won't lessen the power. My brother-in-law suffered from an incurable brain disease. He knew that he faced a future of suffering for himself and emotional agony and financial hardship for his family. He didn't want to continue to suffer or to have drawn out palliative care. He was a take action kind of guy. So he took his gun and went into the garage and shot himself in the head. He died alone. That's not how I want to die if I am terminally ill. I don't want to shoot myself. I don't want to suffer or elongate it. I want to die on my own terms. I ought to have the right to die that way. I ought to have the right to make the choice. Please vote yes for SB 1076. Thank you.
Thank you so much. And I'm so sorry for your experience. I'm so sorry.
Thank you.
Representative Palm has a question or a comment. Representative Palm.
Yes, briefly, Mr. Chair. Thank you, Ms. Copeland, for being here. In your opinion, before your brother-in-law became ill, did he suffer from mental illness or depression? Because
Oh no. This guy was he was a happy-go-lucky, sense of humor, wry, sarcastic. No, absolutely not. He was not depressed. He was not suicidal. He was a guy who liked his life and liked his friends, and he just didn't want to. He didn't want to be in a hospital stuck with tubes and having somebody wipe his rear end, as he put it.
Right. Well, because one of the things that I think all of us on this committee are wrestling with is the distinction between suicide and physician-assisted death. And a lot of the people who testified today are saying that there is no difference. I think some of us feel there is a very dramatic difference. So the reason I asked that question is, in your mind, there's no conflating his mental state with what he did.
Absolutely not. It was a choice. It was an ugly choice. He died alone in the garage, but it was a choice that he felt was his only option because he foresaw a life of misery and pain and suffering for himself and for his family, and he just didn't want to do it.
Thank you. Thank you, Laura. Thank you, Senator Anwar.
Thank you. Ms. Copland, thank you again for your testimony, and thank you for being with us the whole day and listening
Yes.
to the conversations.
Thank you, and good luck to you. Thank you for your hard work.
We are honored. And the next person on our list is Deborah Holland Murray. Welcome, Ms. Holland Murray. You want to unmute yourself, please. There you go.
Hi, sorry. I'll try to get through this without having a coughing fit, but I have a very bad cold. Co-Chairman Anwar and Co-Chairwoman McCarthy Vahey and distinguished members of the Public Health Committee. I'm Deborah Howland Murray from Bridgeport, and I thank you for this opportunity to testify in support of SB 1076. My physically healthy, depressed, and desperate aunt leapt from her 14th story balcony. That was suicide. My husband of 34 years died a painful death from renal cell carcinoma while at the hospice center. He tried everything to cure the disease because he wanted to live as much as my aunt wanted to die. Cancer was a gift, he said, his words, because it taught him a lot about loving and living well. It was a time of great sadness, but I want to talk about joy There was much humor. There was very deep intimacy and soul searching together, and an unbelievable spiritual connection. So early in the days of Dave's illness, we had the crazy idea to express our joy plotting a wedding rerun. It kept us moving inexorably towards the positive. There were medical setbacks, but Dave refused to cancel. 5 weeks before he died, we had our celebration, and we even had our dance. It would prove to be the last dance we would ever have. He was so weak that I had to hold him up. During this, he had only one wish besides spending more time with our very large family, and that was to die in the time and manner of his own choosing. Dave was anything but suicidal, and I believe that aid in dying is the ultimate palliative care for people with physical, not mental, illness. Aid allows terminally ill people to take control over an imminent death process that has already begun. Tethering it to the connotation of suicide misconstrues the issue and disrespects the dying. And the association really breaks my heart in the way that it tarnishes the joy and love of Dave's last months, and it denies him acknowledgement of his unfailingly positive outlook. There was no miracle cure for Dave, but there could have been miracle medication if he hadn't died waiting for aid in Connecticut. And I also want to add that the slippery slope goes both ways, that it is just as possible that if this bill is passed, that people who generally oppose it will want to add more and more restrictions. I believe that neither will happen. I hope neither will happen. Thank you so much, and I'd be very happy to answer any questions with what voice I have.
Thank you so much, Deborah, for your testimony. We appreciate you being here with us for the whole day and your very important words. We heard them. We will be following up. Seeing no other questions or comments, we will ask the next person on our list to speak, which is Phyllis Ross. Phyllis Ross, 103. We see you. You need to unmute yourself.
I thought I had.
Good, you are unmuted. You're good. Go ahead and speak. We don't see you though. Oh, now you're muted. Ms. Ross, you're muted now. There you go. Okay, go for it.
Okay, all right, all right, you don't see me, but you hear me, I assume.
Good.
I am Chairman Anwar and Chairman McCarthy. I'm Phyllis Ross, a supporter of SB 1076. This bill is essential. It is the most humane way to aid terminally ill patients who wish to pass away in peace and dignity. It is not a mandate. It is optional for both patients and doctors. This bill has worked well in Oregon for 26 years, and similar laws now exist in 10 states and Washington, D.C. I watched my mother's unfortunate death. She suffered for months after doctors diagnosed she was terminally ill. She could not walk or dress herself and had to be fed. She was incontinent, couldn't sit up by herself, and had to be turned in bed to prevent bed sores. She experienced extreme pain, but she rarely complained about pain. What she could not bear was how totally helpless she felt. She had lost her autonomy and repeatedly said, "My wonderful life is gone. I can't go on like this." In her last few months, she chose hospice care, but they could do little to help her other than administer medication to lessen her pain. I kept thinking about Mom's words. I can't go on like this. I thought, I know I would have felt the same way in her circumstances. How would you feel? We've heard from people who oppose this legislation, many of them for religious or personal reasons. One person said that every day with her dying loved one, she would give love and care, and that would be a blessing. Well, it may be a blessing for the loved one who is not dying, but how does the one who's suffering feel? I say to those opposed to this end-of-life option, realizing you are choosing what you want, not what the suffering patient may want. The patient's beliefs and wishes should be what matters, and that's what SB 1076 will allow. Members of the Public Health Committee, you have the authority to give terminally ill patients in Connecticut a compassionate end-of-life option, to die in peace with dignity. I ask you, please vote for SB 1076. Thank you.
Thank you so much for your testimony, Ms. Ross. Seeing no comments or questions, we will move to the next person on our list, which is Ann Jackson. Ms. Jackson, you're on.
I am on.
Yes, you are. We don't see you. We can hear you.
And do you want to see me?
Always.
I can't see how I can be seen. Anyway,
Go ahead.
members of the Public Health Committee, thank you. My name is Ann Jackson. Tim Appleton already introduced me as a former CEO of the Oregon Hospice Association. From 1988 to 2008, I was OHA's voice for Oregon's Death with Dignity Act, before, during, and after it became law. I am now an independent and unaffiliated consultant. Since 2014, when I first testified, my support for aid in dying has grown only stronger, personally as well as professionally. I was the hospice caregiver to two men. One with pancreatic cancer died in 1996 while under palliative sedation. He had been experiencing unmanageable and frightening symptoms. The other, with prostate cancer, ended his dying in 2019 using Oregon's Death with Dignity Act. Each was diagnosed with advanced metastatic cancer not long after we became engaged to be married. I was with each when he died. Because aid in dying was a legal option in 2019, Bill's death and dying was far better for him and his loved ones than John's death in California in 1996. When John died, aid in dying was not an option. Both men died at home in their own beds. Both hospices were excellent. Both men had plans in case things went wrong. Both had guns, but John's plans included suicide. He had been stocking up on pain meds, none that would have offered him a good death. Bill's plans included the ODDA. Once he had the meds in his possession, he was able to enjoy living for 2 more months until the dying took over. I had been convinced that aid in dying was unnecessary if Oregonians had access to hospice and palliative care. I believe now that adding aid in dying is the best possible just in case. I strongly recommend that you pass SB 1076. Thank you.
Thank you so much for your testimony, Ms. Jackson. Seeing no questions or comments, we may have some questions. We'll probably reach out to you after tonight. It's a bandwidth issue. Next person on our list is Jeffrey Gardere. Welcome.
Thank you so very much. And I know in the interest of time, I will speak as quickly as possible and hope everyone is safe getting home tonight or wherever you may be traveling. Good day, chairs. Good evening, members of the Public Health Committee. I'm a board-certified clinical psychologist and ordained minister and professor at a New York medical school. And I understand the concerns of the opposition who equate terminally ill adults who want the end-of-life care option of medical aid in dying with people who unfortunately take their life prematurely. But scientifically and factually, it is incorrect to equate terminally ill adults who want the end-of-life care option of medical aid in dying with people who unfortunately take their life prematurely. Many, if not all, considered to be incompetent at the time that happens, and that is certainly not what medical aid in dying. You must be cognitively competent. According to the American Psychological Association, they agree with me that these two terms are fundamentally different. As well, the American Association of Suicidology also argues medically and legally, physician aid in dying and suicide are conceptually different phenomena. But I want to discuss something that perhaps we may not have touched upon with other speakers. I teach about lifelong healthcare disparities that we're all aware of for Black and Brown communities. We don't talk enough about these end-of-life healthcare disparities. For example, versus whites, African Americans are far less likely to have completed an advance directive. They are more likely to have their pain underestimated and undertreated as people of color. They are less likely to receive opioid analgesics. They are less likely to use palliative and hospice care and more likely to die in ICUs versus their white brothers and sisters. My concern is that by silencing or denying the need for medical aid in dying as an end-of-life treatment option for all people who qualify and are in need of it, we will create a stigma concerning conversations about death and dying, and that stigma will be even greater in the Black and Brown communities, where we already see that stigma where they do not talk about death and dying. But just as seriously, cutting off conversations or equating suicide to medical aid in dying will not only exacerbate the end-of-life disparities that Black and Brown people already experience, but they will be made to suffer even more needlessly as part of a medical system that I am part of, where they are already suffering needlessly. So just to close, medical aid in dying must be made available for the people of Connecticut now. There will always be too many terminally ill dying people in Connecticut who are and will be unnecessarily suffering at the end of life. And many of those are people of color who are already victims of substandard care and health disparities from the beginning to the end of life. And the reality is that there are too many terminally ill adults from every race, religion, gender, and attractionality who passed away advocating for passage of this law. We owe it to all of them to provide an end-of-life care option that offers peace and comfort. The time to pass the bill is now. And I thank you so very much, all of you, for your patience in my talk.
Thank you so much, Mr. Gardier. I'm glad you spoke because I had heard somebody speak earlier and say that this issue is not of the minorities. I was hoping that somebody would be able to come and refute that. Could you expand on this a little bit so that we make sure that there's no confusion when we have more conversations?
Yes, there is absolutely no confusion in my mind and in my experience and what I teach in medical schools, that there are health disparities that Black and Brown people are experiencing. Now we see much of it is based upon implicit bias, not enough physician and healthcare provider training, but we see that the end of life healthcare disparities are very real with regard to palliative care and hospice care, and even not having the information about medical aid in dying. If we kill this legislation, if we kill this information, as I said, we will see this as yet being another health disparity, another option that Black and Brown people are not aware of. So this is a very real issue for people of color also.
Thank you so much. Seeing no other questions or comments, we will move to the next person on our list, which is Lynn Colville. Ms. Colville, thank you so much. Welcome.
Thank you for that. Wow, it's been a long day. I applaud all of you. My name is Lynn Colville, and I'm from Westbrook, Connecticut. This is my first time and testifying on anything. And it's been a really wonderful experience being here. I thank you for the opportunity to talk about SB 1076, an act concerning aid in dying for the terminally ill. I, at the beginning, wanted to put in medical aid in dying. I mean, a medical assisted suicide, but I have learned that is not the term to use anymore. I have supported medical aid in dying in theory for many years. It has informed my living will and the end of life care and intentions. I've had difficult conversations with both my lawyer, my doctor, and close relations as to what I want at the end of my life if I am unable to express my wishes myself. I would like to thank everyone who has been involved in writing this bill for its clarity, for being clear, concise, comprehensive, and extremely thoughtful. I urge your support of this bill. Again, I thank you for this opportunity. I have much gratitude for the committee and your compassion and sensitivity that I have experienced all day long. It's been really an honor to be here. I would also like to thank your administrative staff for their professionalism and help in helping me get through this. Thank you.
Thank you so much. And couldn't have said it better, because we are blessed to have the finest administrative staff in this building over here. And it is actually our honor that you have been able to be with us and then share your experience and your perspective, which we truly, truly value, Ms. Colville. Thank you.
Thank you very much.
Representative McCarthy has a comment.
Yes, and Senator Anwar read my mind. It was a comment. Ms. Colville, I hope that this is your first time testifying. I hope it will not be your last. And I very much appreciate you taking the time to engage and reach out and be a part of this process, along with all of the other people who have been with us today. It's been an honor.
On a different bill, please. With that, we'll move to the next person on our list, which is Mary Beth Abrams. Ms. Abrams, welcome. And I see you patiently parked on the passenger side of the car. Welcome.
Yes, yes. Thank you so much to the Public Health Committee for providing me the opportunity to Zoom today. I'm actually working out of state in the field. So my name is Mary Beth Abrams, and I support SB 1076. I know you've heard the name Kim Hoffman a few times today. She died from ovarian cancer while fighting for medical aid in dying in the state of Connecticut. She was my friend, and I'd like to talk about her for my testimony because her life had such a positive impact on me. About 15 years before Kim passed, she watched her mother die from cancer. Her mother was on hospice and had access to very strong pain medication. But her mother was also one of those people whose cancer pain is not alleviated by meds. And because of that, at the very end, her mother begged Kim and her family to do anything to end her life. But they couldn't do anything because they lived in Maine before medical aid in dying was an option in that state. Watching her mother die in pain without being able to do anything about it really burned a scar on her psyche that never went away. And so years later, as Kim's own life neared the end, also from cancer, just like her mom, her fears grew that the same thing was going to happen to her, and that her wife would end up bearing those same scars that come from watching a loved one die in, I'll say it, in agony. Kim's fear was understandable because her own challenges with cancer pain were similar to her mom's. Pain meds did not work with Kim the way they were supposed to. She even had a nerve block procedure just weeks before she died, and that also didn't work. And so Kim fought for medical aid in dying here in Connecticut, only to die while the bill was being debated right around this time last year. Some people ask, would Kim have actually used the medication if it were available? And I don't think that's really what matters. The point is that if she knew that the prescription was available, then the fear and anxiety that grew as she got sicker and sicker could have been replaced with comfort in knowing that if the pain became too torturous, that she could end her life peacefully. Kim lived a service to others with a commitment to nonviolence in a manner that most people just talk about but don't do. And after 8 years of working really hard to fight her disease, she deserved the one option that would have made the greatest difference in the quality of her life at the end. So to conclude, maybe people watching, people thinking about this could never imagine ever choosing medical aid in dying for themselves. But that's not what this is about. It's not what we think we might want for ourselves in our final days, nor is it about our religious beliefs. It's about having compassion for others. It's about imagining what our mothers and fathers might want when their time comes, or our brothers and sisters, or our friends like Kim. So please vote in a way that represents what 70% of Connecticut residents say they want. Vote yes to SB 1076. Thank you.
Thank you so much, Mary Beth, and thank you for your testimony. And yes, Kim Hoffman has touched everybody whose lives she has been able to interact, anyone she's interacted with. Whether you agreed with her or not, every legislator would say that she was a force of nature whose impact and the ripple effect continue at this time. Seeing no questions or comments, we move on to the next person on our list, which is Shannon Sanford.
Hi.
Hi.
Good evening. Can you hear me okay?
Welcome. Yes, we can. Welcome.
Thank you. Good evening, Co-Chair Anwar and McCarthy Vahey and honorable members of the Public Health Committee. Thank you for the opportunity to provide testimony in support of raised Senate Bill number 1076, an act concerning aid in dying for the terminally ill patient. My name is Shannon Sanford. I'm a registered nurse and I have a doctorate in nursing education and a master's as an oncology clinical nurse specialist. First, I'd like to thank the committee for their efforts on Senate Bill 1075, an act to improve hospice and palliative care, a bill I also support because comprehensive quality palliative care is essential for our patients at the end of life. The establishment of a hospice hospital at home pilot program with a combination of in-person and telehealth visits will serve to increase patient access to services while allowing them to remain at home. And I don't believe this to be a redundancy to our current offerings, but rather an enhancement, and one that I wish was available to my family when my father was terminally ill. While I urge the committee to pass 1075, I also must implore you to support Senate Bill 1076. In my experience as a nurse, the best hospice and palliative care will not control all suffering. Suffering is unique to the individual. Florence Wald, who is largely considered the founder of the hospice movement in the United States and here in Connecticut, once stated, there are cases in which either pain or the debilitation that the patient is experiencing is more than can be borne. The American Nursing Association, the ANA, which represents the interest of the nation's 4 million registered nurses, guides nurses on the ethical decision-making since medical aid in dying is legal in 10 states and in Washington, D.C. The ANA encourages nurses to have respect for patient self-determination and a non-judgmental support for patients' end-of-life preferences and values, self-determination and self-determination, prevention, and alleviation of suffering. They further clarify this by stating, in states where medical aid in dying is legal, patient self-determination extends to include terminally ill patients' autonomous and voluntary choice and informed request to self-administer medication to hasten their death. The nursing profession provides their ethics and guardrails that guide my practice. And as legislators, when you vote to pass Senate Bill 1076, which will be the strictest aid in dying legislation in the nation, it will guide the other part of my practice. I'd also like to mention that medical aid in dying is not synonymous with euthanasia. Euthanasia is inconsistent with the core commitments of the nursing profession and would profoundly violate the public trust. The key distinction is that medical aid in dying requires capacity for making a medical decision and self-administering the medication, all safeguards that SB 1076 requires. I've addressed these safeguards in detail in my written testimony, And I've come before the Public Health Committee numerous times testifying in support of medical aid in dying. SB 1076 is the most comprehensive and safest bill that has yet to been drafted. And I applaud the committee for their hard work on this bill, and I fully support its passage. I'd welcome any questions you might have. Thank you for your time.
Thank you, Ms. Sanford, for your testimony. My esteemed co-chair has a comment or a question.
Thank you, Mr. Chair, and thank you to Shannon. Thanks for your comments on 1075. And I have a question for you. You said that you think that it's not a redundancy, but will enhance the pilot program.
I do.
Enhance current offerings, and I'm wondering if you can just briefly say a little bit more about that, because what we heard earlier today in testimony was that this would be a redundancy and that the current law really covers this already. So just if you could just elaborate just a tiny bit, that would be great.
The current offerings for hospice home care, we do have an offering where during the last, the most aggressive forms of hospice care, they offer what they call 24/7 in-home hospice coverage for patients who are at the end of life. And while they do say, or they believe that this does cover the patient, this bill 1075 offers a much more comprehensive level of support with the telehealth visits and the in-house visits from the nurse. My own personal experience with my father when he was on hospice service was the 24/7 support was not comprehensive enough. I can recall a personal incidents where we had called hospice service for help, and the 24/7 support was, well, we don't have somebody that we can send out to your home. Perhaps you can call the fire department to come out and help move your loved one. It was constantly an issue where there wasn't someone available when we needed them. I think having the telehealth visits available on a daily basis would be much more comprehensive. I think having a registered nurse that actually is available to come out to the home provides much more comprehensive coverage. And I think that piloting such a program in Connecticut, where the hospice, where the hospice was founded, is a place where we can actually see real change start. Like I said, the 24/7 hospice support, yes, it's a telephone line that you can call, where they may or may not send somebody to your house, or they may just advise you over the telephone and expect you as the primary caregiver to be the person that provides the care. And I don't think it's comprehensive enough.
Thank you. Thank you for that answer. I appreciate it. And I also want to thank you for talking about the American Nursing Association and their guidance in the states that have already legalized medical aid in dying. That was also helpful. Thank you, Mr. Chair.
Thank you, Madam Co-Chair. And Senator Summers has a question for you, Ms. Sanford.
Yes, good evening. Thank you for being here. I can't see you. I can only see my chair right now, so it's a little strange. There you go. Nice to see you. So I just wanted to talk to you a little bit about, oh, you're gone again, about this bill. This bill came out of a conversation that I had with someone who is the head of palliative and hospice care at a well-known hospital here in the state of Connecticut. And what we were trying to do in this bill is to take the care that you get in the hospital for hospice and bring it home. It came after COVID, where we had a program called Hospital at Home. So what we wanted to do is bring hospice hospital to the home. We have repeatedly heard, even in testimony tonight, that sometimes hospice at home cannot provide the level of comfort or care that you can get in the hospital. So you can have hospice care, but then when the pain gets to a point where it's impossible to manage, that person has to go into the hospital. So the idea behind this bill was to pilot a program with either Hartford or New Haven, with Yale or Hartford Hospital, to develop a hospice hospital at home that would be reimbursed at the same level as what the reimbursement is in the hospital, which is another whole story of why care in the hospital gets difficult based on the reimbursement. But the reimbursement would be enough to cover an RN and to have this 24/7 coverage and availability of a clinical provider for that patient at home, which we really think would make all the difference between telehealth. And they talked about providing an iWatch to the patient that can measure when the pain becomes increase, but based on heart rate, et cetera. But to be able to have that kind of service, in essence, bringing that hospital home. And that's what this bill was intended. So I think I have been floating between 3 different public hearings today, so I didn't have an opportunity to discuss that with the people that testified. We already do this. This is not what we already do. So I just wanted to get your thoughts on that quickly while we had you here.
No, I think that's absolutely correct. We do not do that to that level in the home right now. So I don't see where anybody can say that we actually do that level of care right now in the current hospice system. We do not, to my knowledge.
So is it your opinion that piloting a program like this, or, you know, with this, I know I'm giving you a broad sort of overview of what it would look like. I really feel that this would be a positive step in improving hospice and palliative care in the state of Connecticut. And I wanted to see, because you've been very forthcoming, and I'm glad that you said we don't do that, because there must be something big and disconnected if I'm talking to the head and he's saying we're not doing that and that's what we need to do. We should look to that. So do you think piloting a program like this by one of the hospitals would be a good start in trying to improve the type of care that is provided through hospice?
I do. I think that's a much higher standard of care than we currently have at home.
Great. Thank you so much for your input and your feedback on that.
Thank you for the question.
Thank you so much. Seeing no other questions or comments, we'll move on to the next person on our list, which is Mr. James Young. Mr. Young, thank you so much for your patience with us and welcome.
Good evening. I'm Jim Young, and I'm from Groton, Connecticut. And I'm here on behalf of the Elder Law Section of the Connecticut Bar Association to express our conditional support for medical aid in dying, Raise Bill 1076, with appropriate safeguards. Please note I've submitted written testimony, which includes 2 conditions to our support, which we request be added to the bill, which we hope could be done as the bill moves forward. One is we believe no caregiver should be a witness to a request for aid in dying. And second, we believe that the attending and consulting physicians should be independent of one another. This bill would give a qualified patient, as defined in this bill, the power and the option, if they choose to use it, to decide for themselves when they've suffered enough to end their lives without suffering through the entire debilitating and possibly painful natural disease process. As you all know, under Connecticut law now, generally speaking, one must endure the entire natural disease process, often with loss of control over one's body, the ability to meaningfully participate in life, and sometimes under severe pain or medications which materially impair the ability of mental functions. It doesn't have to be this way, and it's not this way in many other states which have adopted aid in dying laws. We believe the state should not interfere in the patient-doctor relationship, as this law does, except where there is some extraordinary power, some extraordinary overriding public policy goal to be achieved, and then only to the extent necessary to achieve that public goal. I note this new bill is substantially changed from the prior year's bills and adds a number of new safeguards. This new bill addresses the state's interest in preventing persons who are suffering from a psychological condition, including depression, that results in impaired judgment, from obtaining aid in dying by adding a requirement of counseling and barring aid in dying unless a counselor and the attending and the consulting physicians all determine the patient has capacity to make the decision. Also, there's a new provision in Section 21 of the bill that requires the attending physician to meet with the patient every 30 days after prescribing the medication to determine the patient remains competent or ensure proper disposal of the medication. Preventing suicide is a valid state interest, but it is wrong and misleading to equate suicide with aid in dying. The argument that medical aid in dying would lead to abuse of the disabled is simply not based on the real-world evidence of how these laws have worked for many years in the many other states that have them. There's no reason to think it would be any different here in Connecticut. Since we believe a qualified patient, as described in this bill, should have the right, if they choose to use it, to make decisions about these most personal decisions, we support medical aid in dying with appropriate safeguards.
Thank you so much for your testimony. We appreciate your testimony and we will take note of all your recommendations and suggestions. Seeing no questions or comments, we will move on to the next person on our list, Mr. Young, which is Paul Bluestein. Mr. Bluestein, you're on. Welcome.
Thank you. Co-chairs, members of the Public Health Committee. My name is Dr. Paul Bluestein. My wife of 40 years, Linda Bluestein, has late-stage ovarian cancer. For the past 21 months, despite the toll taken by the cancer and chemotherapy, I've watched her fight to live as normally as she can. She wants to live as much as she can and as well as she can. But one day, that won't be possible any longer. And when that date comes, she wants to be able to say enough and die peacefully on her own terms. I've been an advocate for medical aid in dying long before this became a personal issue. I've heard opponents say they have concerns with medical aid in dying, as if the concerns haven't been thoughtfully addressed during the 20 years since the legislation was first proposed in Connecticut. As if this hasn't been available to people in Oregon and Washington for decades without issues. As if medical aid in dying isn't accessible right now to people in 10 states and Washington, D.C. I want to know who it is that thinks they have the right to preempt the most difficult medical decision that someone could make in consultation with their family and doctors. Doctors like to think of themselves as healers, and we are. But there are times when there is no more healing that's possible. And when that time comes, we need to be honest and compassionate and respectfully heed the wishes of our dying patients. Medical aid in dying is being denied by a vocal minority using misinformation and fear to block what most people in Connecticut want. In more than 2 decades, medical aid in dying legislation has never even once been permitted to come to the General Assembly for a vote. Never once. Isn't it time, way past time, to allow terminally ill patients the right to choose how and when they will die? Please support Senate Bill 1076. Thank you.
Thank you, Dr. Bluestein. I have Representative Berger-Giavalo who has a question or a comment.
Yes.
I just want to say thank you very much, Dr. Bluestein, to you, to Linda, for continually coming out to support what you truly believe in, and with your understanding and practice, the practice of your own, it means as much as it would if you were speaking as someone who needed this for your own benefit at this moment. I know that you do on a different level, but I just very much appreciate that you continue to fight for this. Thank you.
I appreciate that. Thank you very much.
Thank you, Mr. Chair.
Thank you. Thank you, Dr. Bluestein. And we appreciate your testimony and your sharing your experience and the pain. We look forward to hopefully doing some good work this session. With no other questions or comments, we will move on to the next person on our list, which is Christopher Rossetti. Mr. Rossetti, welcome. You're on.
Good evening. My name is Christopher Rossetti. I live in Avon, and I strongly support Raise Bill 1078. I'm sorry, 76. I was born, raised, and largely educated in Connecticut, and then practiced law in Metro Hartford, primarily in the probate field for 41 years. Why must I pick up and leave the place I call home to die in dignity? 10 enlightened states and the District of Columbia have already enacted medical aid in dying legislation. Responsible polling suggests that a supermajority of Connecticut citizens want it. Our governor has indicated he will sign it if passed. It should be noted that nothing in this bill would compel anyone to do anything they find immoral or improper or do not wish to do. This bill does not compel anyone to seek medical aid in dying. There's no evidence of abuse by this type of legislation in the places that has been law for decades. The testimony by the proponents of this legislation today should be entirely persuasive to those with open minds acting rationally. Although I was raised as a Roman Catholic and attended a Jesuit prep school, I find myself embarrassed at the early medieval and paradoxical quality of the testimony of the Catholic clerics here today. In my career, I met only one dying person who found his or her late-stage suffering either redemptive or dignifying. My experience is completely at odds with the charming Father Sullivan's assertions to the contrary. Catholic legislators need to reflect on whether their religion may interfere with their service as responsible representatives of the people and defenders of our civil liberties. Please release this bill. Many thanks to the co-chairpersons who have presided so competently over this contentious hearing. Many thanks also to Compassion and Choices, to the many articulate proponents of this legislation who have testified today, and the many stalwart legislative champions of Physicians Aid in Dying legislation on this committee. Thank you.
Thank you so much for your testimony, Mr. Rossetti. We appreciate your patience with us today and staying with us for the whole day.
My pleasure.
Seeing no other questions or comments, I will have Professor Andres Sofer, who's next. Professor Sofer, welcome. You're on.
Thank you, Senator Anwar and Co-Chair McCarthy Vahey, and to the committee. I am a practicing academic physician, and I'm here to testify against the proposed bill. From my perspective, I look at legislation from three simple vantage points. First, what is the problem it is trying to solve? Secondly, is it enforceable if safeguards are not followed? And third, are there better alternatives? So first, what is the problem the bill is trying to solve? I think that many of us, many physicians have seen patients whose physical pain and emotional misery could have been better managed at the end of life, and a lot of family members and others have testified today about that. Some see the proposed legislation as a solution to end-of-life suffering, a way to give the patient and their families more autonomy in how these final days are spent. And although I strongly advocate for the patient to be the center of all end-of-life decisions, I have many concerns about this particular bill. First, although the bill requires that death will occur within 6 months, we as physicians are not as precise in our timing of death as you might think. Secondly, although qualifications of the attending and consulting physicians are proposed, how do you, as a patient, know that your attending physician made the correct diagnosis and then referred you to an independent and most appropriate consultant to render a second opinion on your care? Instead of taking medication to end your life, perhaps what you might need is an independent decision from a more specialized physician. Lastly, and for the first time this year, the bill requires that the attending physician shall refer the patient for counseling to determine whether the patient is competent to request aid in dying. However, I could find no mention of the qualifications of the individual who make this determination. 2, is it enforceable if safeguards are not followed? The bill mandates that the physician report to the Department of Health on patients for whom they are assisting, including their name, diagnosis, prognosis, and that all requirements have been met. It also states, presumably to give assurance that no malice will occur, that any attending physician who fails to act in good faith when determining whether a patient meets the requirements in order to request aid in dying shall be guilty of a Class B felony. These all sound really good in theory, but I can assure you that there's no possible way for lawmakers or law enforcement to find their way into our examining rooms, our hospital, or the home where the decisions are made or deaths reported. Just look at the existing examples that people have talked about already to find how commonly the letter of the law is not followed. In Holland, 60% of cases were not completely reported to the authorities. In Oregon, less than 5% of suicide cases were referred for psychiatric consultation. Additionally, if we allow aid in dying, are we then required to legalize euthanasia to protect those too debilitated to take the medications themselves? 3, are there better alternatives? I think that we would all agree that the end of our lives must be handled with the utmost care and expertise from our team of medical providers. I also believe that we must do better than we are in end-of-life care, including management of pain and anxiety, as well articulated by so many family members today. As a doctor with over 35 years of experience taking care of all kinds of patients at home, in the hospital, going to hospice, in nursing homes, and also teaching the art of medicine, it is my firm belief that we doctors must not be put in the position and our patients being given an expectation that we could possibly give medications for the ending of life.
Excuse me, Professor, but your time is up. Thank
I
you.
have 2 more sentences. Although I think the intent of our legislators may be good, I think the resultant bill is misguided. And I think that as you are doing, you should advocate for and fund programs that teach us to well provide end-of-life care and give our patients the best diagnostic modalities and treatment for their illnesses, as well as expert palliative care. This is the kind of care that I and my colleagues advocate for every day at our own hospital and clinics. Please walk with us and support us in this journey so that we can deliver the best care that our patients deserve. Thank you for allowing me to give this testimony.
Thank you so much. Senator Heather has a question.
Yes, thank you, doctor, for being here at this late hour. You mentioned that you would like to see us advocate for improved palliative or hospice care. I wasn't sure if you had the ability or was listening previously about our bill concerning hospice hospital at home to try to improve the hospice quality and availability at home. One of the things that we were looking to pilot was basically to bring the hospice hospital into the home to look at having more direct care with a nurse at home that could provide a higher level of pain relief and using telehealth, et cetera, to provide a better experience with hospice at home. I didn't know if you heard that, so I'd like to get your thoughts on that. And then secondly, I just had a question. I know it sounds like you really dissected the intent of the bill with some questions in certain areas. I was wondering, if this bill moves forward, what your thoughts are on the attending physician who makes the referral. In your opinion, do you think that physician should be trained in palliative and hospice care to be able to make these decisions?
Thank you very much for your questions. In response to your first question, I did hear that testimony and I did hear your response to that. And actually, I was recently on service at my own hospital where we did refer patients for hospital at home through our own hospital. And it's a wonderful program. There's, as you mentioned already, there's telehealth. There's the ability to have a nurse's aide there 24/7 to take care of the patients if they need help with bathing, with toileting, with food, etc. And I do agree with, I think it was Ms. Shannon that talked about the fact that sometimes patients cannot get the immediate care at home that they need when they're on hospice, and people are having anxiety or they're having pain and the family doesn't know how to give the medications and it takes time for the nurse to get out there. So I think having a more aggressive program where people can actually get the care that they would have otherwise had in the hospital, if they can get that care at home with their loved ones in the comfort of their own bedroom and not in the sterile hospital environment, is excellent and I think would work and go a long way to giving people the care that they need. So I applaud what you're doing there and thank you for that. In terms of your second question, should all physicians or should the attending physician be trained in palliative care? I don't know that that's necessary. I think that all of us, in particular, the attending physician that we're talking about, must be well trained as a diagnostician and to make sure that they're making the right decision. They can then refer to the patient to a subspecialist, say they need to see an oncologist, a pulmonologist, or whatever they need to make sure that they get the expert care that they need. And similar to at our own hospital, I'm not trained in palliative care. I know how to deliver, I think, standard end-of-life care within the hospital, but I oftentimes will call on my colleagues in palliative care to give me help. And I know when I've reached my limits. So I think that the doctor needs to be well trained to know his or her limits, to make an appropriate diagnosis and appropriate referral. And sometimes then they can refer to a palliative care physician. I think it would be too much for the legislators to try and train all of us in the appropriate level of palliative care that's necessary. I think it's better that we know how to have a good referral pattern and that our patients have the access to the care when they need it.
Thank you for that answer. The reason I ask is because talking to some palliative care doctors at Yale, they had indicated if a physician was going to basically be writing the script for somebody to end their life, they thought that they should be trained in palliative or hospice care before they had the ability to do that. And that's the only reason why I asked that question. And I appreciate your answer and your time tonight.
Thank you very much.
Thank you. Thank you so much for your testimony. Seeing no other questions or comments, we appreciate you being here. I see Ann Manuski, who is number 70. I don't know what had happened with the Connecticut Republican Assemblies. Miss Manuski, I think you were probably not available at the earlier time. You're welcome to speak now.
Correct. Thank you, Chairman Anwar. Chairman Anwar, Kushner, Marks, Cabrera, Rahman, Slop, and Ranking Member Summers, Gordon, and members of the Public Health Committee. I'm Ann Manuski, Connecticut resident for over 24 years, wife, mother, as well as former licensed professional counselor, and current president of the Connecticut Republican Assembly. The Connecticut Republican Assembly has members and friends totaling over 500 Republicans and conservatives across the 8 counties of Connecticut. We stand firm in our principles and unalienable rights under the U.S. Constitution, as well as the rights and responsibilities within the Connecticut Constitution. In a review of SB 1076, which in essence is a bill that has been in the works in Connecticut in various iterations to aid in dying for over 10 years, here are 2 critical excerpts. 2, aid in dying, meaning the medical practice of a physician prescribing medication to a qualified patient who is terminally ill, which medication may be, in which medication a qualified patient may be self-administered to bring about such patient's death. Number 3, attending physician, meaning the physician who has primary responsibility for the medical care of a patient and treatment of a patient's terminal illness, and whose practice is not primarily comprised of evaluating patients, qualified patients, prescribing medication, or dispensing medication pursuant for aid in dying. God our Father has put us on this earth to do good. Our founders wrote the Declaration of Independence and created our United States of America with life, liberty, and the pursuit of happiness, also within the Connecticut Constitution. We are not moving towards pushing for death, although there are members of the General Assembly who continue to push this assisted suicide agenda. Those individuals with severe illnesses due to extreme issues have the ability to assert for palliative care, which provides aid in their well-being through the course of their life. Palliative care has existed in Connecticut since 2013 from my research. Further thought, the Connecticut General Assembly lawyers should be reviewing concepts and bills for their constitutional merit. Why has this even been raised? This is a violation of the Constitution. We're about the freedom and liberty and life of people. Vote no on SB 1076 and any other bills that infringe on the rights of the citizens of Connecticut. Thank you.
Thank you so much for your testimony. Seeing no questions or comments, we appreciate your patience and being with us today. And next person we have on our list is number 120. I want to see if Amanda Weech is here.
I'm
Okay, good. Welcome.
I unfortunately do not see an option to turn on my camera.
Okay, well, you can speak then. You've waited all day, so we are looking forward to hearing your experience and perspective.
Thank you. So good evening, Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Amanda Weech, and I am an MSW student at the UConn School of Social Work. I'm here delivering testimony in strong support of Ray's Bill SB 1076. Recently, being a caregiver to my grandmother who suffered a brain hemorrhage that led her to her terminal diagnosis of heart failure has given me a deeper understanding of what dignity and end-of-life care truly means. I was there to witness her last days down to her last hours, where she was completely disabled with excruciating pain, with no real autonomy over her body and care. The value of worth and dignity of a person does not stop in end-of-life care, as many patients like my grandmother do not want their last days to be riddled with suffering and unenjoyable life and the loss of dignity in the eyes of their loved ones. As much as I know my grandmother would not utilize this care option, I know in my heart she would want others to have the choice. So I ask you to put yourself in these patients' shoes, where you're being faced with a life that only exists to be poked and prodded by numerous doctors, needing assistance from others to carry out basic life functions, and ultimately not partaking in any of life's enriching activities you once enjoyed. What would you choose? What would you be thinking? You are also meeting for a bill concerning dignity in palliative and hospice care, and I believe this is a start in the right direction. I can imagine that this dignified care option would come to mind for many patients, as 96% of those under care using the Death with Dignity Act in Oregon mentioned a fear of loss and dignity in their life and their care being the main factor in their decision. Aiding terminally ill patients in their death allows for this loss of dignity to be restored and at the forefront of a patient's care, ensuring that the individual's wishes are at the core of any palliative or hospice care they receive. By using a self-administered lethal dose prescribed by a medical professional, a patient can choose how, when, and where they will come to the end of their life. As an advocate for someone who wanted dignity in their death, I ask you to please vote in favor of Bill SB 1076 to allow the 75% of Connecticut residents who favor this option to feel dignified, in control, and heard in their end-of-life decisions. Thank you for your time and your attention.
Thank you, Amanda, for your testimony, and thank you for staying with us the entire day. And we truly appreciate your words. With that, seeing no questions or comments, we will move to the next item on the list. And the next item on the list is a big thank you to a number of people. Amanda was our last person to testify today. Thank you each and every person who has come to speak, either in person or virtually. We are so appreciative of each and every person who has spoken today and your perspective. We value it, we respect it, and we will keep that in consideration as we move forward. And I wanted to thank each and every member of the Public Health Committee who have been part of the conversations today, whether they've been here or not, or both places, whether they were remote or in person. And we had asked people not to ask too many questions. And the reason was that we wanted to get most of the people who are here to testify at home at a safe time with the weather changes. So we appreciate that as well. We will have most likely more conversations going forward. This was very helpful, but this was seamless because of a number of reasons. One of those reasons is our amazing team. I wanted to just take the moment to thank our Madam Administrator Beverly Henry for her strong work and leadership and keeping this ship running and sailing in the right direction, along with other team members, including David Kaplan, Dave Ratcliffe, Kathleen Panazza, Kate Hamilton, and also today we also had the team who's been putting this into YouTube. And yes, and I'm not done yet. Peter Kolakowski, who is the intern who's been there, despite being asked to go home, he just stays on and fights the fight with us. And we're so happy about each and every person who's been there. Along with that, we have our LCOs, Eileen Lawler Parker, Nicholas Panzarella, and also OLR Nicole Doobie and James Orlando, who have been with us throughout the day, along with my co-chair and ranking members and each and every one. So thank you, thank you, thank you. And my co-chair has a comment as well.
For Senator Anwar, thank you for all those thank yous. We actually have another speaker who we have, and I'm talking with that wonderful team that Senator Anwar was talking about, who is literally, they never stop working. So if you could just bear with us for one moment. Thank you, Senator.
Well, you'll have to hear my speech all over again for thanking everybody because we have another speaker. Maybe the speaker will say they don't want to speak because of my speech. Who's that person on the list? Deborah McCauley is still on.
Can you hear?
Yeah, we can hear you, but we
Oh,
cannot.
wonderful. Thank you. I'm sorry.
You joined at the last minute after my speech, Deborah.
You had an awesome speech. Thank you very much for giving me a moment. I just had a family obligation that I had to address. I do want to just say that I am very much for this bill to pass. I'm a registered nurse as well as a mother and grandmother. I've had both of my parents pass as well as two of my siblings, and I feel very strongly that individuals should have the privilege and the opportunity to make a personal choice. And seeing many individuals in my field, patients, have struggled and their families, I think that it's incredibly important that people have the opportunity to make this personal choice. Thank you for your time.
Thank you so much for your testimony. We appreciate your testimony and we thank you for that. I hear there may be another person. We don't think so. We're just, now we're being like little, very sure. We do? We do not. Okay. Okay, we'll just wait for a second, just for a second. You want to? No. Yes, Representative McCarthy, where he will make a comment.
Thank you, Mr. Co-Chair. And I think we're waiting to work out one final online kink maybe. But in the meantime, I just wanted to say thank you to the members of the committee as well. And I know Senator Anwar did, but Senator Anwar, who was at the helm for the bulk of the day, to the committee members for their thoughtful engagement, and absolutely to every member of the public who was here, both in the Zoom room and online, participating in this thoughtful dialogue. End of life is an issue that impacts every single one of us as humans. So it's a difficult and at times very painful conversation. And for those who shared their stories and their journeys in particular, I am grateful. And I am going to pause for a moment so we can just double check if we have that last speaker. Thank you, Mr. Chair.
There was somebody who had signed up by mistake to the Judiciary Committee today who was supposed to sign up with us. And so he's ahead of the curve because if this bill passes, it may go to Judiciary, but the person is not signed in here. So with that, we are going to call it a day. I will not start my speech to thank people again. But I do want Senator Summers to have her comments as a ranking member. Thank you.
Well, I would just like to thank everyone who came today. I know this is a very emotional topic. I just also wanted to reiterate, if you didn't see a full house here, there's many other meetings going on at the same time. So committee members were in and out throughout the day. And I hope everybody has a safe ride home or is safe where you are. I'm sure that this bill will get a lot of attention in the next few weeks. And again, it's really important that you come out and have your voices be heard, so we can understand what you're thinking. If you haven't had a chance to be here, you can still submit written testimony under the bill number. We heard 1076 and 1075 today. And I want to thank my co-chairs for their excellent job in running this committee today, especially with the weather coming. and the committee members for keeping their comments short. And I would now like to ask Senator Anwar to once again do the closing.
And with that, we close. Thank you.